Hello, thank you for taking the time to learn about physician assistant practice in Utah. My name is Dr. Jonathan Baird. I am the past president of the Utah Academy of Physician Assistants. In the late fall of 2019, a survey was performed amongst physician assistants in Utah. What follows are the results and summary of that survey. According to data from the Utah Medical Education Council, in 2019, there were 1,541 PAs practicing in Utah, with just over 89% of them providing their medical services in the state. Comparing that to the previous UMEC report in 2014, that is a 32% growth, with an annual growth rate of about 8%. Of those PAs practicing in Utah, 62% of them are native Utahns. Let me discuss the survey methodology. It was an 8-section survey. It was distributed via SurveyMonkey, and 3 emails were sent to 1,195 members of the American Academy of Physician Assistants and or the Utah Academy of Physician Assistants living in Utah. And that took place from November 6th to November 19th of 2019. 308 people responded of the 1,195 people contacted, for a response rate of 26%, which was enough to reach our confidence interval of 95%, with a margin of error of 5%. When compared with similar surveys conducted by SurveyMonkey, we were pleased with the response rate as well. I'll discuss the demographics of the respondents and direct the audience to cross-reference this with the demographics listed in the Utah Medical Education Council report on physician assistants in 2019. And you will see that the demographics are very similar, and thus we believe this to be a representative sample. By gender, 52.3% of respondents were male, 45.8% female, with a small minority preferring not to respond. The age range matches well with the known demographics of Utah, and the lion's share of respondents fell within the 25-year to 45-year-old range. The majority of respondents identified as Caucasian. The most prominent minority category identified was Hispanic. Those responding to the survey, by and large, were either practicing in suburban or urban locations, though 18.3% of respondents identified as practicing in rural Utah. As one might suppose, there are a variety of practice settings in which PAs practice, and this survey certainly corresponds not only with that supposition, but also with other surveys done by the Utah Medical Education Council, which corroborate this data. And the same is true with those responding about medical specialty, with a strong percentage of respondents reporting that they were practicing in family medicine. Almost 81% of respondents were employed full-time. The first issue that we queried the respondents on was the supervising physician model. The issue at large in the nation is that many physicians and PAs work in group practices or hospital settings where laws that require PA physician agreements sometimes interfere with their ability to make practice-level decisions about patient care teams. We asked the respondents, as a PA, have you been personally affected by this issue? 56.2% responded no, they had not. However, 30.2% answered affirmatively, with another 13.6% unsure as to whether or not they had been personally affected by the issue. It is when we get into the qualitative themes, where respondents were able to respond with free text, that we start to get an idea about how this is affecting them. The following responses are considered typical The second issue was phrased, currently, the retirement, sudden relocation, disability, or death of a physician with whom a PA has a delegation of services agreement, or DOSA, may mean the PA can no longer provide healthcare services to patients, even if the PA has been their primary care provider. We asked the respondents, as a PA, have you been personally affected by this issue? We then asked them, do you worry about this issue? First, when asked if they had been personally affected by the issue, thankfully, 86% said no, they had not. But 11% of those people said yes, they had been affected by it. When asked if they worry about the issue, the majority of PAs indicate that they do. When getting into the qualitative themes, we see just how people have been affected by this in Utah. The second issue that we asked respondents about had to do with direct payment from third-party payers. The issue was phrased like this. PAs are not eligible for direct payment from Medicare and nearly all commercial insurance payers. Most payers require that payment be made to a PA's employer, which can unintentionally limit PA employment opportunities. It also makes it nearly impossible to collect practice data for PAs because everything is linked to the physician. We asked the respondents, as a PA, have you been personally affected by this issue? 58% of PAs indicated yes, they had been, while 16.9% of PAs were unsure. A quarter of the PAs responded said they had not been personally affected by the issue. In the qualitative theming, we get more details. The third issue that we queried the respondents on was regarding regulation, that is to say, how PAs are regulated by states. We phrased the issue to the respondents thusly. In Utah, physicians are regulated by a medical board composed of physicians. Nurses are regulated by the nursing board, made up of nurses. PAs are regulated by a board that has 3 physicians, only 2 of which are required to have experience working with PAs, 3 PAs, and a lay public member. Some argue only PAs, or at least a PA majority, should constitute the makeup of the PA Regulatory Board. We asked the respondents, do you agree with this statement? 82% agreed that only PAs, or at least a PA majority, should constitute the makeup of the PA Regulatory Board. 9% maybe, the rest said no. In the qualitative theming, the respondents elaborated. We went on to discuss the delegation of service agreement and said, when PAs have a specific supervising physician by the delegation of services agreement, or DOSA, their employers may lack flexibility in creating healthcare teams. The agreement also allows for physician liability for the care that PAs provide when physicians are not involved, and increases physician and employer risk of disciplinary action for administrative reasons. We asked the respondents, as a PA, have you been personally affected by this issue? 69.8% of respondents said no, they had not been personally affected by the issue. 20.8% said yes, they had, while 9.4% said they were uncertain. The qualitative theming revealed additional details. We then phrased the following to the respondents. Physicians often report to or are supervised by another physician, senior or chief physician. PAs may function in a similar system and even report to a senior or chief PA in some systems across the country. We asked the respondents, are PAs employed as supervisors of other PAs where you work? 70.8% said no. A quarter of the respondents said yes, they were. The qualitative theming reveals important details. What we found is that issues that are present nationally are also present here in Utah. Therefore, we propose the following solutions in modernizing PA practice in Utah. First, it is proposed that we eliminate the legal requirement for a specific relationship between a PA and a physician, or any other healthcare provider for that matter, in order for a PA to practice to the full extent of their education, training, and experience. This can be verified via the credentialing and privileging process that these providers go through anyway. Additionally, physicians should not be held liable for the care provided by PAs when the physician is not involved in the case, and that PAs should be fully responsible for the care that they provide. A small adjustment to the PA Regulatory Board is suggested in that rather than having 3 physicians, 3 PAs, and 1 layperson, that we have 2 physicians, 4 PAs, and 1 layperson, thus constituting a PA majority board, while still retaining physician representation. Finally, PAs should be authorized to be eligible for direct payment by all public and private insurers. These policies, if implemented, should lead to greater, not lesser, access to high-quality health care for Utahns. Employers of PAs in Utah will have more flexibility, not less, in determining the constituency of healthcare teams. Legislators should see increased access and lower Medicaid costs, and physicians will be relieved of unnecessary administrative and legal burdens. In speaking of these recommendations, Bill Feinerfrock, the executive director of the National Association of Rural Health Clinics, had this to say, quote, "The changes PAs are seeking represent a natural evolution of the PA profession. Patients, especially in rural and underserved areas, will benefit from greater access to the high-quality care that PAs provide." Drs. Kathleen Adams and Sarah Markowitz of the Brookings Institution's Hamilton Project said, quote, "Removing unnecessary restrictions on PA practice, such as eliminating the requirement for PAs to have an agreement with a specific physician in order to practice, would help alleviate healthcare shortages and improve efficiency with no adverse effects on patient outcomes. The U.S. Departments of Health and Human Services, Treasury, and Labor issued a report in 2018 entitled Reforming America's Healthcare System Through Choice and Competition. Among other things, they stated that states should consider eliminating requirements for rigid collaborative practice and supervision agreements, in this case, as we're speaking of physicians and PAs. Thank you for taking the time to understand issues that affect PAs in the state of Utah and the solutions that can help deliver high-quality, cost-effective care to Utahns.